Okay, I think we're just about ready to start. It's just turned 12:30, so I will make a start with things now. First of all, welcome everyone. It's nice to see you all, and hopefully everyone's doing well, especially given the current situation. First of all, I'll just introduce myself briefly. My name is Tom Carter. I'm the Junior Coordinator for the European Forum for Primary Care. Myself and my colleague Diederik, who's the coordinator of the forum, will be facilitating today, and the moderator, Martin Sprenger. So just to give you a quick overview, first of all, the rules of the working group. So first, I'm going to ask that the webcams be turned off and microphones muted. This is just to avoid sort of a lot of chaos going on in the background if there's noise and things like that. Right. Also to make sure the Wi-Fi is good for everyone. We did divide the participants and observers, obviously, into two categories. So we have observers. So if you are an observer, you would have received an email telling you that.
Hallo.
And if you have any questions or comments during the...
Ja, also kein Webinar, sondern eine Fokusgruppe.
Then please feel free. Sorry? I couldn't hear you there, Sarah. Okay. Well, so if you are an observer, then again, please keep your webcams off and microphones muted. But if you have any questions or comments, please feel free to add them into the chat box. And then we will record this and keep a record of everything. Participants, if you do then want to say something and contribute, we'd ask you to please switch on your microphone or your webcam when you're wanting to speak, so our moderator gets an idea of who's going to say what. And please keep that to one at a time, and of course be brief in your stories and comments, so we only have an hour today. And yeah, so without further ado, what I will do is hand over to my colleague Diederik. He is offering a video, as you can probably see on your screens here. Diederik, do you want to briefly explain what you're showing there?
No, I'm not going to explain. I'm going to show and then hand over to Martin. In 30 seconds, Martin, you can start. Let's go ahead.
Normally, we have at least 10 patients waiting for doctors. But since our government has advised to stay home most of the time, our patients are much more like waiting at home, and very rarely visiting our primary care unit. Let's move.
Martin, floor is yours.
Okay, thank you very much. I think the video has shown a hospital which is very empty. So yeah. Okay. Hello everybody. Yeah. I'm very happy that this thing is happening. So, and I'm looking forward to 1 hour of lots of discussions. The reason why we are here, I think it's obvious that all health systems at the moment in Europe and outside of Europe are in a kind of COVID-19 modus, and this is not a real regular modus for health systems. And if you look at Austria, patient pathways are very complicated, usually in a normal mode, and they are more complicated now. So, and this influences, of course, how we deal with acute or chronic illness in different settings. So not only in the setting of hospitals, as we have shown in the short video, but also in the setting of primary care, maybe in the setting of rehabilitation, in the setting of long-term care, but of course also in the setting of self-care, because many illnesses or chronic diseases are dealt with in self-care. So today I want to discuss with you, with the focus group, about how these non-regular mode of health systems, how its impact on different groups, and we called it like collateral damage, which is under the radar at the moment. So are there any observations of collateral damage? What are the causes? Who are the vulnerable groups of collateral damage? And maybe at the end we will talk about some strategies. So I would like to start with observations. So if you have a case study which you think is symptomatic of the situation now in your country, please just go forward and tell us the story. Who wants to start?
I should put on my camera. Hello, my name. Sorry. Can you, Martin, say which one is going to be first?
Yeah,
go ahead.
Start.
Okay. Well, my name is Dineke Smit. I'm from the Netherlands, and I'm specialized in mental health. And what we see is that there ain't hardly any contact, physical contact, not also on 1.5 meter distance with the patients and with people on low status, living with chronic psychiatric problems. So that's quite an issue. As long as it was just only for 2 or 3 weeks, everyone said, okay, it's okay. We did a lot with e-health online, but now it's during much longer. You see that the patients are more suicidal, more anxious, and the field of mental health is struggling what to do. And our union or association is telling, keep distance. But on the other hand, you're a healthcare professional, so you have to do something. So for mental health, it's quite a struggle.
Okay, can you just tell us about the groups? Are you talking about children or maybe all age groups, or it's yep?
Yeah, both. As well as for children and as for adults. And especially for adults, but also with children, you don't, if you have communication through Zoom or like this meeting, you don't know if anyone else is in the room, if they are alone and you're speaking about very private subjects. So, and we, especially with children in not safe homes, it's quite difficult to what we do. And I think the policy about mental health and Corona is very, very weak.
Okay, can you just make a statement on inequalities, how you observe them?
It's especially for the we call it low socio-economic status. Those people are very vulnerable because they don't have internet. They don't have a very nice environment. They don't have help from schools for children, and that's a subgroup in the Netherlands is always vulnerable, but now with Corona even more.
Yeah, might I like to add something?
Sure.
Well, this is Maria van der Muizenberg from the Netherlands as well. I'm a GP and caring for a homeless population and vulnerable migrant groups. And in addition to what Dini says, it's the same we see, and especially anxiety is growing in migrant groups because we get information from other countries that migrants are disproportionately affected and dying from the virus, and at the same time they often lack the precise information on the confinement measures the government has taken because they have difficulty following the Dutch instructions. So there's a lot of anxiety in those groups, and there are no means in personal contact to really comfort them. That's one thing. Another thing we see is that in the homeless population and in other groups, that addiction care has closed down. So people who were just started with, for instance, a drug addiction program now, well, they can get still their medication, but no support or no counseling. So that's, we see, is also troubling a lot of people. And another thing is that we noticed that's more about another group, that pregnant women And I had a case of a woman who did not want to go to the hospital because she was very much afraid that in the hospital she or her baby would catch the illness, and therefore she was very reluctant to call the midwife, and then waited very long until she really had some problems. So I think in terms of inequality, we see that this, as always, the most vulnerable have the most problems. They get the most anxiety and stress, also related to lack of income and other more social consequences of the measurements. But they also, I'm afraid, will be the ones who suffer more from the illness itself.
Okay, thank you very much. Any other observation from somebody?
Ian Walton from UK. Can you say something about the mental health situation in the UK, Ian?
So I think to speak, I'm actually retired as a GP. I was speaking to my practice this morning, so I could give you the latest updates, really. And they're saying, actually, I think people, the way that the service being set up is and all through telephone triage, and actually phone calls have generally dropped by 50%. And actually, because none of the doctors are ill, they're actually finding, you know, the workload has actually gone down. They're seeing everybody over the, well, they're triaging everything. So each doctor's only actually seeing face-to-face about 2 patients a day, and the rest is all work over the telephone. A lot of that is calming people down on worrying about symptoms, and some of it. But I think actually what's perhaps happening, I mean, we know that they're talking about letting chemists and things give out methadone without prescriptions, and there's an awful lot of happening under the surface. And you know, the police are definitely observing a lot more domestic violence, and I think there's very much still the focus is very much on, you know, what do we do about the acute symptoms of the illness, because I mean, for instance, the practice manager is actually she has caught it, but she was self-isolating beforehand, so she's he actually wasn't in contact with anybody, but you know, there's definitely you know, there's a lot of COVID around in the UK without being picked up because we don't have tests. Only the people admitted to hospital are actually being recorded in the statistics. So there's an awful lot of anxious people. But if you have any COVID signs, they're being diverted to a single practice where they see people, and everyone else is diverting away. So I just think it's a lot is buzzing under the surface, and I'll be able to report more after tonight, because I'm joining the, you know, self-help group of GPs and looking at this, because of course I think everyone's staying very calm as GPs on the whole, though I mean, if my practice, for instance, had to buy all their own safety equipment. It's still not being distributed yet. So I think we may be, I mean, one of the reasons I think Britain's in the mess it is, and the figures are probably well down, and the Americans are saying we may have the worst final figures, is because actually we were a week or two behind everyone else locking down. And I'm very interested that, you know, we were really 2 weeks in, and looking at Italy, for instance, and Spain and things, when they got to 3 weeks in, the whole atmosphere seems to have changed, and people's mental health seems to have, you know, it's starting to affect people. So I think perhaps we're still in a little bit of a honeymoon period, if you like, and I wouldn't be surprised if we don't catch up with Holland, like Dinniker and the other doctor was saying. And it'd be interesting to know if it's only really in the last week or two, whether that's really come to the fore in there.
Okay. Thank you. Sorry. Thank you very much. I just want to ask also the observers. You can put some questions into the chat room. So the chat room is open for questions. So Go on, whoever. Yep.
Oh, it's Ken here, Ken Eaton.
Yeah, I can hear
well, first of all, thank you very much for inviting me to take part. I'm a little bit distant because I'm actually a dentist by background, but I do a lot of work in Europe, and that's why I've been invited. Just to follow up on what Ian was saying from the UK point of view, Ian, I think one very positive thing that's happened is that our homeless are being offered hotel accommodation. Are you aware of this? To try and get the people off the streets and rough sleeping.
Yeah.
Were you aware?
So I haven't heard it. I think in Austria I have heard something, but I'm not so sure about. Yeah,
because the hotels can't open for normal people. So these people who really have a tough time, a lot of them, of course, have got addiction problems and mental health problems. So in a sense, that's a positive thing for them. From a sort of a dental point of view, some interesting things. I understand that in Ireland, dentists who are on salaries are being seconded to general medical duties. And that's very good. In the UK, the dentists are in contract with our government service, the NHS, are having some protection of their fees. But the ones who are in totally private practice, I think, get no protection whatever and still have to pay their staff. And I suspect that will be true, particularly in places like Italy and Spain, where there is virtually no publicly provided insurance for oral health. But that's really a bit of a sectional interest for me, I suppose. So I think I've said quite enough, and I will just sit here and listen to what you've got to say. And thank you again for inviting me.
Thank you very much. Elena from Greece, could you please tell us your observations, how it is in Greece?
There is very little I can tell you because number one, between Maastricht and Crete, although we are every day 2-3 hours on the call, but mainly because Crete is lagging behind from the rest of Greece. We had a couple of dozen people only so far. So we are estimating that in Crete, because of the way geographically it is positioned and because of the measures being enforced relatively early, we think we're lagging behind in the mainland 2 to 3 weeks, and we think Greece is lagging behind 2 to 3 weeks to the rest of Europe, and even more than a month to Italy. But we're anticipating numbers to rise, particularly because we are seeing a lot of debate on tourism for Easter and on relaxing measures and so on. Having said that, in terms of triaging and testing and so on, we have very intense discussion for migrants. I do not know how many of you know, but we have already had in 2 out of the 3 biggest camps, we have cases. And technically, you know, this is very harmful to the people. Anyway, the conditions are harmful to their mental health and to many other, you know, infectious disease aspects, including, of course, COVID-19. So this is already there. We have seen a lot of debate, which is harming social cohesion, because in a way, it was lucky that the first case was somebody that had gone to a fashion show in Milan and not a refugee, because had that been the case, I do not want to contemplate what the reaction of the people would have been to refugees and migrants in the current climate. There is a lot of anxiety and worry on the advice and the provisions being, if you like, both from WHO and coordinated and from the EU, very conflicting, and the personnel for healthcare professionals for primary care and not only having limited and confusing guidelines. I know that many colleagues, including in the Netherlands and Germany, think they have received very good information. But because I come from a molecular oncology background and testing, I mean, I see argumentation which is very troublesome with very little understanding on the different types of testing. So we're trying to do a little bit of education, you like on that. And I do not know if any of you are participating. We had, I mean, in Greece, we are, some of us. We had a 5-hour session yesterday on the infodemic with WHO, and we have a session which is running today also from 2 o'clock to 5, 6 o'clock. So we see a lot of fake news, a lot of misinformation. With the chloroquine, I do not know how many of you knew, we had a very bad situations because people went and bought Plaquenil off the pharmacies without prescription, and the pharmacies actually gave it out. And this is very, very worrisome. And we also have some discussions which pertain to preparing primary care. Indeed, in Crete, we're starting with the first mobile units at the moment, which took 2 months to convince central government to do it, but okay. There is the discussion, I think we also had it with some colleagues in Germany, that people were being sent to central structures, reference hospitals and so on, to do testing. And this was showing that there was lack of understanding on how to utilize primary care networks. And then there are 2-3 other points which are worrisome. We see a lot of antibiotic prescriptions without differential diagnosis, so there's no real syndromic testing per se. If somebody is being treated for symptoms which are not subsiding, because testing could be inconclusive at 30% false negative is the gold standard. So people get a lot of antibiotics, so we're very worried for AMR aspects and for increased prescription of antibiotics. We're also worried for unnecessary exposure of personnel, and we are even more worried for what will this mean in terms of provision should the numbers go up. And in all honesty, we are in kind of anticipation that the numbers go up, but remaining optimistic. I hope I captured everything. Sorry, I'm going too fast. Yeah.
No, thank you very much. As some of you mentioned before, that so maybe the first 2-3 weeks are very different to people. For example, people with chronic diseases or mental health issues are very different to if the health systems are staying in this mode for maybe another 4 or 5 weeks. So maybe things could get worse. So would somebody comment just on maybe chronic diseases, because especially chronic diseases, people need medication on a regular basis, maybe need some kind of monitoring on a regular basis, and what is happening with all these people with diabetes or cardiovascular diseases? You think they are well managed, and can we keep this kind of quality up for the next 4 or 5 weeks?
Maybe one of the dietitians joining us, giving some ideas about these chronic conditions. Is there somebody? Shanna Huisman or Jose? No.
Yeah, or just a GP want to comment?
Yes, I could comment from the Netherlands. What we see is a really dramatic fall of all kinds of GP consultations that are not really concerning COVID-19 complaints. So up to this moment, there are virtually, as for instance, we have monitored this for the GP practices around Nijmegen, and there are no regular controls of diabetes or hypertension whatsoever. Of course, this indeed doesn't matter so much for a few weeks. So this is not of much concern at the moment, but we expect that when this goes on for longer, and it is expected in the Netherlands at least to go on until June 1st, this will indeed result in more people with high sugars, etc. Chronic medication is not a problem in the Netherlands because it is issued always online, and people can just get their recipes and go to the pharmacist. So that's not a problem, but the controls and the support of self-management and then people get worse. That's not monitored at all.
Okay, thank you very much.
Lorena
yeah.
from Germany, chronic conditions.
I also wanted to comment quickly on that question, Eva from Austria, but I have 4 points, and chronic diseases is just one. Like my colleague who is mainly treating diabetic or is treating our diabetic patients, she also mentioned that point to me. She said it's getting difficult. We are working mainly with homeless or poor people or migrants, so it's not the most reliable population. So once you get those patients to be in a certain routine, and then you now have to postpone the appointment, it remains to be seen how long that will be working well, and how long the hypertension or diabetes management will work well without routine appointments, so we're actually already waiting to be able to call them back in. Second, we also had a case like for routine examinations that you need. It's difficult to get appointments for special doctors because you never know who is open, who is not, who is doing what. We had one woman who wanted to have a mammography and she was having pain and she was having symptoms but not having a note, but like the institute said the radiography should be postponed, while we were of the opinion she should do it now. And we also have a few. Can I mention also the other issues about homelessness and migrants? It's a few points.
Yeah, sure.
So for the homeless people, we have that the issue, where do you quarantine them? So we will have start a new project in Graz that, like has been said, a hotel will open for quarantine and we will do the medical follow-up there. But we didn't have anything 2-3 weeks ago. Then the homeless people, they don't have a general practitioner doctor. They do not have a phone to follow up on them. They do not have a temperature. They cannot measure the temperature. And they don't have the money to buy masks. So if the general recommendation or even duty to wear masks will be coming, one will have to think how to do with the homeless people or the poor people. Also, especially those having lung problems. And as for the migrants, our main hotline in Austria is only provided in German. So, and on the public news sheet, it's written then call the hotline, but please bring somebody with you to interpret. And nowadays you should not be with anybody that doesn't live in your household. So if no one in your household speaks German very well, it will be difficult to get information through that hotline. Some interviews of asylum seekers have been postponed, which is also a mental stress for the people concerned. And then we had two new cases. Two new things that popped up we didn't think of, that drug addicts, they are not taken into substitution programs at the moment, and it's difficult for them to deal on the street. So we have more drug addicted people now coming to us. They wanted to have not a real substitution, but with Collateral, whatever, and it's very hard for us to do, and these people are getting more. And second case was two citizens of other countries that the flights were cancelled and they were staying in Austria and couldn't get HIV treatment, one from Greece and one from Ukraine. So these are the cases that I wanted to mention. Thank you.
Okay. Yeah, thank you very much. At the moment, we are talking a lot about risks and negative kind of collateral damage, and I will shift to some positive experiences as well, as mentioned in the chat. But before I do that, I want, maybe you have to comment, because we have also people who are who have cancer and rely on regular treatment, or who have kind of operations are postponed, surgical interventions are postponed. So any observations about that? So hospital treatment postponed?
Right. Two comments from me, Tom. So for FNA, for diagnostics for cancer, pretty much everything has been cancelled, which means potentially tumor progression or to diagnosis of 1 or 2 months, which could be lethal for most people. And for island medicine, and this is when you really need to go to Athens or somewhere centrally to have procedures, this is really disastrous. And then additionally to this, there are some comments, there are some positive aspects on health, I think mentioned by Alice and other colleagues, but I think Eve mentioned languages, and there was also a suggestion by somebody of sending languages. I had a very brief exchange, Didrik, with Ivana and with the AMA. They are producing some things which we all need, as for example, we've seen in the debate of ibuprofen, and as for example on the information for chloroquine, the producers in English is not being adapted. I haven't seen it in Dutch, I have not seen it in German, I have not seen it in Greek, and I've talked to them and they said they do not have the resources or the time to do it. I've also talked to the DG for translation in the Commission, they have also not had time to do it. So this is a little bit concerning or worrisome, if you like, because the trouble is that we have theoretically the resources and they have the mandate, but they appear to be thinking that producing information is in English is sufficient both for healthcare professionals and for patients, and that, unfortunately, to me at least, is unacceptable. I mean, this is within the mandate of the Commission. There's no objection to that from the TFEU, and the resources are very basic, and it's not happening. So I would like input from other colleagues, whether they are aware of this or whether they think it's a problem, and of course whether we should do something about it.
Yep. Any comments on that?
Shuba, can you
I would like.
Go ahead, Maria.
Well, I totally agree with that it's unacceptable. In the Netherlands, we have prepared in different languages information for patients, for the public, on the measurements and on risks, but not covered all the for instance, the fake news that's on hand. We try to, every time then when there is something substantial, we try to adapt it to in different languages, as well as to make it easy for people who have difficulty understanding difficult words. So probably if you send me, Elena, the information on the ibuprofen or other issues you think are important, I could see what we could do at Pharos to translate it and to adapt it, and we make visual information sheets of that and spoken also.
It's on the EMA website, Maria, but it should come from either from ZIN or CDZ, or it should come centrally. And RAVM, I talk with Ora Tiemann because we both UFA and so on. I have very basic things on English and some things on Dutch. I have seen nothing, absolutely nothing adapted for the layman.
I agree. Also, at this moment, the RIVM in the Netherlands is also, we are working together to get this information. But indeed, the difficulty is that the official government sites don't want to get any information on it that they didn't develop themselves. So that's indeed a problem. But on the other hand, we see that it's now being distributed at a wide scale among primary care professionals, hospitals, midwives. So I think, at least in the Netherlands, we have quite a good range, but it would be, of course, it would be much better when it would be on official sites as well. We're discussing this still with the government.
A little bit the same of in Greece, but I think, yeah, I mean, I haven't seen it as a patient in the Netherlands, in Germany, in England, or in Greece. So, but it's nice to hear that it is there. But I mean, if I go now to find something, the EMA released this information some time ago. I think another trouble is that the EMA does not send us this information when they produce it. They rely very much on social media and on their website, you know. And on fake news, this is something else to discuss. Perhaps, I do not know if you have heard all this vinegar drinking and chloroquine drinking and so on. But yeah, perhaps we can do something from the narrative. I've asked some people to put it in Pi, but I think they're a little bit embarrassed to do it in Greek. Although we did ask them to do it in any language that was easy for them. And the question, I also have a question for the group, and Maria, perhaps you also thought about this. Do we want to collect stories from patients and from migrants and from people? Yeah, because PI is for professionals, I think.
May I just comment on this? So we started 2 weeks ago, we started in Austria an open Google Doc, as an open Google Doc document, and we are collecting cases from different settings, as I mentioned in the introduction, and we have about 150 cases already, and I also ask social workers, GPs, nurses to send in cases, so we can build up, we get more insight just by case studies, stories. Yeah, it was very interesting. I can recommend it to every country. Yeah.
Can I add something to that? That's really marvelous, Martin. I think we could try to collect all these different stories and experiences in the Netherlands, as well as Crete and in the USA. We are just starting a small scale qualitative research on the experiences of vulnerable groups, with all the measurements and the information, and also a survey among primary care professionals. So probably I could share this also, and we could try to, in one way or another, to combine all the experiences and information we get, so we have a more robust body of knowledge about it after some time.
Yeah, Maria, our collection at the moment is more on the health professional side, so we are not collecting stories on the kind of people side. This would be also very important in my opinion.
Yes, so indeed. I will circulate a proposal.
Okay, well, to respond on how to collect, I think we have been struggling with how to, as an EFPC, how to collect those stories and information. We set up Pi, but it seems to be not the ideal way to collect. So we might do it in the same way as Martin now suggested for Austria, to open a Google Docs account for that. Anyhow, let's go ahead. I saw that.
Dirk, just one, because I think this is a very good strategy. To this kind of collection is a very good strategy for everybody to participate and to get more insight. If you look at these case stories, but what is very important, that somebody is at everyday base is looking through the document, is organizing it, formatting it so that it looks tiny, organized, and also make chapters. And so that's very important. So it's that's what we do in Austria.
Yeah, clear.
Yep.
Let's move on to maybe to Turkey also for some additional information on what we have been discussing. Serap, you were showed in the video when we started up, but do you have some additional information from Istanbul?
Hi.
Hi.
Hi, everybody. Yes. Well, it is a little bit difficult in Istanbul because we have so many cases, much more cases than other parts of the country. And however, it is in the beginning of the outbreak, we were a little bit less organized, but nowadays we are much better right now, and we are keeping up with the patients. On the other hand, there are some vulnerable groups that it is not very easy to reach out. There are so many people who are not registered in our system, immigrants, both immigrants from other countries and immigrants from other cities of Turkey. Since there are workplaces, the workplaces are open, and in Istanbul there is a huge mobility of workers, and they are coming from other cities, and they are normally registered to family physicians in other cities. So when they are in Istanbul, they don't have easy access to healthcare system, which is a problem for us.
Okay.
Yes.
Yeah, go on.
Another problem we are experiencing here in Istanbul is the lack of coordination between systems of primary care and tertiary care. It is very difficult. It is sometimes so difficult to find patients and their contacts, and normally it is done by primary care workers in the field. But most of the patients are coming to the hospitals and they are seeking care or seeking help for testing. However, it is the job of primary care, so it is a little bit difficult to find patients. And it is, since our patient lists are very crowded, especially in the socially deprived areas, it is not easy to find cases and their contacts in primary care, and it is even harder for the physicians in social deprived areas in Istanbul.
Okay, thank you very much. I just want to open up another setting, because in the high risk group in our societies are the elderly, and many of them live in long-term institutions or are their families taking care of them. So Of course, they are a risk group, but also the kind of health system or the caring system in COVID-19 modus changed how we are dealing with them. Is any comment on these groups of the elderly? Is there anything different for the elderly in long-term institutions in your country?
In Turkey,
Well,
yeah. In Turkey, it is forbidden for the elderly to go outside now in Turkey. People over the age of 60 cannot go by themselves outside, so they are in need of help of others. The residential institutions are advised to close their doors to any visitors. We are making most of the time the healthcare of these institutions by digital platform, and we are working with the health workers in these residential institutions. The elderly in their homes we are following up these people by most of the time by phone calls, and however, there are some elderly people who are living alone, of course. Not very much in Turkey, but there are, and it is a problem really. Now the organizations, governmental organizations, are bringing groceries and other things in these people's home, but it is a problem. It's always a problem for the primary care physicians in Istanbul to make a visit to those people, because our lists are so crowded. Primary care physicians cannot do all these work all the time, so it is very difficult for a primary care physician to visit all of his elderly and to provide care for them in their homes. So it is more like by phone. Even that is difficult.
Maria, you wanted to say something about it?
Yeah, and Tineke as well, I think. But maybe first, Maria.
Oh, okay. Well, okay. Thank you. Yes, in the Netherlands, the main problem is that the people were living in facilities for the elderly or home care institutions are not allowed anymore to get visits. So that's very sad for them and very disturbing for the people with dementia who don't understand that. And especially also in this, the elderly migrants are affected worse, because many of them live in institutions where the professionals don't speak their language, and they are always supported by their children, for instance, in communication. So this is a real problem. At the same time, some migrant organizations have already installed remote support and information sections. Another thing that's disturbing me is that we got information that in institutions, that people with mental disabilities who live in institutions and who were infected were refused at first instance by the hospital because of their mental disabilities, although they were in good health before they got ill. So we are also very much worried when the intensive care capacity falls, that, for instance, people with mental disabilities, and it is already said that elderly people will not be referred to intensive care, and not by medical reasons, but just by, well, selection of the fittest to go there. So that's another thing. I think it's quite worrying.
Okay, Tineke?
I just wrote down my my comments that there's especially for mental health problems there is a special unit in one of the hospitals for it, but then it will be very long distance from the home support or the family. And I think to add, as Maria already said, that the vulnerability of the elderly, especially when they don't come out of the houses, they don't move anymore, they are lonely, they are well, that's not doing anything good for your health at all when you're lonely. And it's also very worrying. I know about one person, she's 90, and her son is just a few days ago diagnosed with a brain tumor, and he's in hospital. He's pretty worse, and she's not allowed to see him. And the other kids, her other children, don't want to see her because she's vulnerable as 90 years old, and it's sad.
Yeah. I think the issue about the elderly is a very special issue. Maybe should do an own focus group about this kind of group, yeah, and children as well. So I want to spend just I just want to spend the last 2 minutes of my 10 minutes, and then maybe you finish up this kind of focus group, and the last 10 minutes on positive aspects. So just stick to positive aspects so that we don't skip them at all. Yeah. What did you observe as positive aspects of this kind of health systems in COVID-19 mode?
I would be keen to have Alice Smith also on the line from Switzerland, I believe. Do you have some experience on that?
Sorry, I'm participating as an observer, so I'll keep quiet for now. Okay. I have been putting a few things in the chat, but thank you. Unless you want me to talk, but
thank you very much, Alice. Okay, then comments on some positive aspects of this.
Ken Eaton here. I think one positive aspect is that family life for parents and children in some families has improved because they're actually eating together more. They're actually together more. Now, of course, the downside of this is domestic violence has probably increased, but I think there has been perhaps an improvement in family life for some people. And another thing which I think will probably happen, and that is in 9 months from now, do you suspect that the birth rate is going to suddenly increase?
I think that was before Netflix. I think that's pre-Netflix in effect.
I'd like to
it's interesting to say this because in Greece the positive effect is finally they're discussing surveillance in primary care context and telemonitoring, but for the elderly it is detrimental because invariably they are not in home care and they do not live with the core family, and they do not get to see the grandchildren. So for our settings this is very detrimental. It really sort of deprives them of social contact, and it adversely affects them, and we get to have reports of that, and we also get to see divine behavior from the elderly wanting to go out. But yeah, you said to stick to positive things, but I want to mention this anyway. We do have from settings where people have had measures and so on, we have reports of family violence increasing as well. So I do not know if it was mentioned in the first 5 minutes I missed, but this is coming also from our social workers collaborating with the university clinic.
Okay. Ian, do you have anything to add from UK?
Yeah, well, great to see, especially with a Prime Minister in intensive care at the moment who has led a government which in the last 10 years has run down our health service. And actually there's finally been quite amazing, suddenly the health service actually, one of their slogans is, well, stay inside to support our health service. And one of the problems is because it's been run down, it's not in a great position to actually cope with the current crisis, or particularly if it explodes. And the other thing that's happened, or hopefully will happen, is our health service is cropped up by an awful lot of foreign workers, many of whom were leaving with Brexit. And were made to feel very uncomfortable. And I'm hoping that we will finally start to really appreciate, you know, that we are an international society and we are all in all this together. And ironically, our government is actually, which being a right-wing government, is actually putting in some quite left-wing programs supporting people financially, and as it was pointed out, getting our homeless off the streets. And so we know that health really is so closely connected to inequality. So whether a positive aspect of this is that we will come out a more equal society or not, we'll have to see. But there is some hope.
Okay.
I think
anything on positive aspects? Otherwise, I hand over to Diederik. Okay, Diederik.
Yeah, we are almost through, eh? Or Tom, you want to finalize, or how are we? Anyway, I was also curious on positive things from Turkey, because I didn't hear you on those things. So Tuba, Serap, maybe one more or two comments.
Okay, the one positive thing happened in Turkey is people are not kissing each other anymore when they meet, and they are washing their hands more thoroughly. So it is a positive aspect, really. And before the outbreak, there was that the people didn't trust health system much most of the time. And they were going to some alternative healers, and these healers were doing more harm than treatment before. However, now, since none of those people have anything to say in this outbreak, people are more trusting to doctors now, I think.
Thank you very much.
Okay, and still, I'm curious. I think Shanna Huisman, can you open your microphone? Maybe you are a dietitian or not? You're not answering. Okay.
No, she's not in the. She's not in the group. I didn't find her name.
I see her in my group. Anyhow,
okay.
That's curious. Okay, but I think well, we have covered a lot of questions by moderated by Martin, and I think Martin, you are going to bring that together with Sarah into an overview on what kind of collateral damage can occur. And you mentioned already that we would like to focus more on sub aspects, like you are yourself a favor in children, but apparently elderly is at the same way a very important group. Migrants are a very important vulnerable group, but at the same time mental health and also disease specific aspects are important, like chronic conditions. So can you put each of you, also the observers, those aspects you would like to discuss more in detail with a similar kind of group, maybe next week, same time, same way? What kind of aspects you would like to see in the chat box? So we have an overview of those preferred sub aspects which can be discussed at a later stage. That would be very helpful.
Diederik, may I just add something? May I just add something?
Go ahead.
What we are thinking about in Austria in the moment is how to monitor this. So is it possible to do it with hospital data? Is it possible to do it with primary care data? So how is it possible, or is it just possible by research projects? And if we do research projects, how could they do it? Yeah, and so this would be kind of strategy of healthcare research, yeah, to deal with this issue. Yeah, but one sentence, Maria. I would be interested in such a group as well, because this is kind of my background, that I'm as a public health trained GP. I would be really interested to get the numbers, yeah, and get more insight by numbers, to get away from stories are very important, but I also want to see some numbers as well.
Yes. Yes, we in the Netherlands are aiming to do a survey of primary healthcare patient records to assess the morbidity and mortality differences between people from different social status, migrant background, etc. So I can send you we have made one big proposal with quantitative and qualitative data. I think it would be great to do some more extensive research in that aspect. So probably I could send it to you, Martin, and then we could, could see if that would be something we could go on further with.
Thank you very much. Yeah, perfect.
Yeah, that sounds good. So if you add all in the chat box your favorite theme, we would be very happy. Next to that, we have already collected some stories, but also collected videos from the practices, like from Serap, but also other places in Ljubljana, Italy, Latvia has sent their contributions. So we would like to spend a webinar on just the general issue, how primary care practices cope with these new challenges with COVID-19. So that is next week, also in the same time slots, but then on Thursday, 16th of April. So that's another announcement. And talking about surveys, we have started our own survey on organizational issues in primary care. So that is this one, and we have separated it in a process and guidance and the experiences and observations. So if you want to add something on this, that would be helpful as well. I think that having said that, Martin, you want to add something on this?
No, thank you very much, Diederik.
No. Sarah, did you have a lot of information collected, and are you able to make a report out of it next to the session, which will be in the evening?
Hello, sorry. Yes, I will try to make a brief overview of the topics we mentioned before, and probably we can have a look on some topics which need more focus. Yeah.
Okay, well, then I think if nobody has a very urgent issue to bring up, which was not mentioned at all and should be noted by Sarah to have a follow-up, tell me now or put it in the chat box. Then we will cover it. As said, at 7 o'clock in the evening, we will have a similar session. Hopefully we might see you next week on a specific topic again. Thank you very much, and enjoy your lunch if you had not yet your lunch. Otherwise, have a good day later on. Bye bye.